Good day, everyone, and welcome. My name is Dr. Anikwe Onwanyi. I am Chief of Cardiology at Moore School of Medicine and Professor of Medicine, and I'm delighted to welcome you today. I'm also the immediate past president of the Association of Black Cardiologists. It is my absolute pleasure to welcome you to the inaugural International Dr. J. Brown Best Abstract Competition hosted by the Association of Black Cardiologists. Dr. J. Brown, who served as the fourth president from 1988 to 92, was a force for excellence in cardiovascular medicine. His steadfast commitment to mentorship and his unrelenting pursuit of health equity left an indelible mark on our profession and hearts. Today, we do more than remember him, we continue his mission. This event marks a meaningful and exciting milestone for our organization. For more than 5 decades, the Association of Black Cardiologists has been committed to promoting health equity and advancing the science and practice of cardiovascular care, particularly in underserved communities. Today, we continue to expand that commitment on a global scale, creating a platform that celebrates research excellence and elevates the voices of diverse emerging leaders in cardiovascular science. We are proud to have received abstract submissions from around the world, each representing innovative thinking, rigorous inquiry, and a passion for improving heart health. To all who participated, and especially our presenters today, thank you for sharing your work with us and contributing to the future of equitable cardiovascular care. This competition would not be possible without the generous support of our sponsor, Amgen. We are deeply grateful for their partnership and shared commitment to innovation, equity, and empowering the next generation of cardiovascular leaders. Thank you, Amgen, for helping to bring this vision to life. To our esteemed judges, thank you for lending your time and expertise to this process. And to our guests and supporters, your presence and engagement today reflect the growing global community dedicated to reducing the burden of cardiovascular disease. Let this be the first of many international convenings that strengthen collaboration, spark new ideas, and move us closer to our shared mission to achieve health equity and eliminate disparities in cardiovascular outcomes worldwide. I would also like to acknowledge our international partners, the Pan-African Society of Cardiology, PASCA, the Caribbean Cardiac Society, the Nigerian Cardiac Society, the European Society of Cardiology, and invite even greater participation of our international trainees in cardiology for future competitions. Also, be reminded that there is already a call for abstracts for the 2026 competition, and you are all encouraged to participate and spread the word. Thank you again for being here. With that, it is my pleasure to turn over the program to our co-presenter. I think Dr. Paul Underwood will be standing in place of Dr. Narisa Ains until she joins us. Paul Underwood, who is the current chair of the board of cardiology, of the board of the Association of Black Cardiologists.
Thank you very much, Dr. Onwanyi, and it is certainly my pleasure to be with you. I am Paul Underwood, the chair of the Association of Black Cardiologists, and it is certainly my pleasure to welcome you all. And certainly thank you, Dr. Onwanyi, and a heartfelt thanks to you for your opening remarks, and also, more importantly, for your leadership in bringing this program to life. This vision began under your presidency, and with your dedication and tireless efforts, we have been able to launch this initiative and others, broadening ABC's global footprint. We are deeply grateful for this. I am honored to welcome our 4 finalists today. Your research reflects academic excellence, innovation, and a shared commitment to advancing cardiovascular health on a global scale. We are thrilled to celebrate this milestone with you. Before we begin, I'd like to take a moment just to walk through the flow of the program. We are excited to hear from our 4 outstanding finalists, each of whom will have 15 minutes to present their research, followed by 5 minutes of Q&A. During the Q&A portion, we will prioritize questions from our esteemed panel of judges. If time permits, we'll also include questions from the audience. Once all 4 presentations have concluded, our judges will be excused to a private breakout room to deliberate and make their final decisions on the 2 winners. A quick reminder to everyone, our judges will select 2 winners from today's competition. Those winners will be sponsored by the Association of Black Cardiologists to attend and present their work at our events during the American Heart Association Scientific Sessions this November in New Orleans. This is a significant opportunity to amplify their work on a national stage and further engage with leaders across the field. While our judges are deliberating, we'll also present a special fireside chat featuring some of our most distinguished leaders in the ABC community. I will be joined by our president, Dr. Anthony Fletcher, and by Dr. Richard Allen Williams, the founder of the Association of Black Cardiologists. This conversation will be a powerful opportunity to reflect on the past, present, and the future of global cardiovascular health and ABC's role in driving equity and innovation forward. We look forward to a meaningful and engaging program. Let's begin with our first finalist. Our first finalist is Dr. Makrina Komba from the Jakaya Kikwete Cardiac Institute in Dar es Salaam, Tanzania. The presentation is Knowledge of Heart Attack Risk Factors and Warning Signs Among Tanzanian Urban Population. Thank you. Dr. Komba.
Thank you, everyone. And good morning from our fellow US. My presentation of today is about knowledge of heart attack, risk factors, and warning sign among Tanzanian urban population. As we all know that cardiovascular diseases are the leading cause of death in the world, and is estimated for about 8 million of deaths every year. And among those, heart attack contribute of 9 million. And in Tanzania, cardiovascular diseases account for approximately 13% of all deaths, and heart attack being a major contributor. And the map in the right displays the mortality rate of heart attack. And that shows that there is higher rates in Europe and Asia, but there is limited data in Africa. We were able to conduct cross-sectional study, community-based, which was conducted in Dar es Salaam on 2022, and a random pre-selection was used to select a random sample of over 1,700 individuals who were all 18 years and above. And this study used validated standardized questionnaire, and in which close-ended questions were used to assess knowledge, and all statistics was analyzed using Stata software, and all tests were two-sided, and p-value less than 0.05 was used to signify statistics. Here is our results. We are able to enroll over 1,600 of participants, and our mean age was 45 years, and female contributed over 54%. In lifestyle, over 71% had excess body weight, about a quarter were drinker, 3% were smokers. Regarding to disease history, over 31% were hypertensive, 7% diabetic, and over 11% had history of high cholesterol. Regarding to history of heart attack, 13% had positive family history of heart attack, over 6% had positive personal history of heart attack. Regarding to risk factor awareness, over 50% of our participants reported stress, followed by unhealthy diet, hypertension, overweight, physical inactivities. But here, the bar chart in red were our participants, about 20% who did not know any of risk factors. Regarding to heart attack warning sign, here almost 3/4 of our participants did not know any of heart attack warning sign, but shortness of breath was reported of 11% of 15% of all our participants, followed by lightheadedness, which was reported of 11% of all our participants, then 7% was reported for chest pain, and others are seen in the bar chart. Regarding to planned responses, here over 50% of our participants reported going to the hospital, which is a good thing, but however, over 1/4 of our participants did not know what to do. But here we got inappropriate planned responses, such as prick to bleed, hit head with slipper, rub with toilet dirt, run away, visit witch doctors, oil massage, pray, give fluid sips. Here is regression analysis of associated factors. As we all see, starting with the knowledge of risk factors, that is in the red colors, participants who were with high level of education, that is secondary level and above, participants with normal, who were non-smokers, normal body weight, participants who were hypertensive, and those with negative history of high cholesterol, and those with personal and family, with positive personal and family history of heart attack, and those who were at risk were having high knowledge compared to the other groups. Coming to the knowledge of heart attack warning sign, that is in the blue color, participant with 55 years and above, and those with hypertension and diabetes, those with positive history of high cholesterol, and the one with personal history of heart attack, and the one at risk of heart attack had higher knowledge compared to the other groups. So in my conclusion, I would say, as we have all seen that our participants had basic plans for responding to this heart attack. However, their understanding of key risk factors and warning signs remain insufficient. This implies that there is a gap in our healthcare system's effort in identify and educate both high risk and general public. And we can address this by strengthening the training to our healthcare providers through basic life support, and also enhance public awareness through strategic social media campaign. Thank you very much.
So thank you, Dr. Komba. Are there any questions for any of the judges? in response to this presentation?
Yes. Hi.
Go ahead. Mhm.
All right, this is Dr. Scanberry. One question about your, say for instance, the response to, so if you think you're having a heart attack, what's the response? Was that an open-ended question, or did you have choices?
No, it was open-ended questions, and we gave them chance to express.
Okay, okay. And coming out of, I'm just wondering if you could expand a little bit on what you plan to do with these results.
First of all, we can start with our referral hospitals by giving them train on basic life support. And this plan also we have started here in our national hospital, and also we are going to the all referral hospitals of Tanzania, and we have 31 regions. So when we educate the referral hospitals, it is easy for this managing this heart attack. Also, now in Tanzania, due to globalization, majority uses social media. So even in our institute, sometimes we are given chances to the radio and TV to educate them about these cardiovascular diseases. So heart attack is the one of the topic.
Okay, okay.
And
Go ahead, go ahead.
Okay, and also now in our country, we are given chances for people to go and learn more. Like now we don't have many cardiologists. Like cardiologists are only in 3 regions out of 31. So now in all regions, our government has planned to give them chance to go to school and also to build cath lab in all region hospital. Okay. So as in government also there are other plans about hospital in also modifying and helping these patients.
Okay, okay. I see there's a question in the chat. Was any assessment included regarding gender differences in heart attack signs as well?
Pardon?
Was an assessment included regarding gender differences awareness of gender, the awareness of the gender differences in heart attacks? Did you ask about that?
It is similar.
So no, I was just wondering if you had asked in as part of your questionnaire whether individuals were aware of the gender differences. This is just a question in the chat, so I was just facilitating.
I didn't understand well your questions, but
so no, it's just wondering if you had one of your questions was to see or was to see if the respondents understood that there may have been a gender difference in signs of heart attack.
No.
You didn't ask. Okay. Okay. Yeah.
All right. May I go ahead?
Yes. Go ahead, Dr. Bola.
Yeah. Thank you, Dr. Komba. My question is the whole concept of heart attack. Obviously, you didn't do the survey in English. I suppose it was, translated into Swahili. I mean, how did you ensure that the perception of what a heart attack is actually what a heart attack is? Because the responses will depend on what they think a heart attack is.
Well, it was validation. It was validation.
I mean, how was the question asked? How did you ensure that what your patient thinks is a heart attack is what really? Because I mean, I know I come from East Africa, and I know you talk of heart attack and stroke, and there are all sorts of confusions. People think one is the other.
We made sure that first, that's why there are people who did not understand, did not know any, because we first ask about, did you hear or do you know about heart attack?
Okay, fine.
Majority said yes,
Yeah.
and then you have to give them chance, like to give them chance, like mentioning risk factors. As we all know, risk factors somehow they go with stroke, heart attack and stroke, somehow they go together. But majority also mentioned in a way we knew that this person know or this person does not know completely. So we give them a room to express about it.
So great presentation, Dr. Komba. Just one final question before we move to the next presentation. Along the same lines of the question that was just asked, did you look at I may have missed that, did you look at the educational level of the responders to kind of gauge a sense of how they responded? Did you take that into consideration?
Yes, I took it as I asked as I used to. We reported if they did not go to school at all, if they have primary level, if they have secondary level of education, and if they went to college or university. We also asked them.
Okay, thank you very much, and congratulations for that work. Excellent.
Thank you.
So you're welcome. So we're going to go to our next presenter, and I have the honor and privilege of introducing our next speaker, Jane Enajeroh from Lagos University Teaching Hospital in Lagos, Nigeria, and she will be speaking on assessing ventricular arrhythmias in newly diagnosed hypertension, a comparative study. Dr. Enajeroh.
Good morning, everyone from Lagos, Nigeria. My name is Jane Enajeroh. I'm a cardiologist in Lagos University Teaching Hospital, and I'll be presenting my paper today called Assessing Ventricular Arrhythmias in Newly Diagnosed Hypertension, a Comparative Study. So this will be my outline. So ventricular arrhythmias are abnormal arrhythmias that come from the lower chambers of the heart, as we all know, and they can range from benign ventricular complexes to potentially life-threatening ventricular tachycardias and ventricular fibrillation. Kushid et al. In 2020 did a study on 500,000 adults and found the incidence of ventricular arrhythmias to be 0.57 per 1,000 person years, and the risk factors were older age, male sex, hypertension, CKD, and heart failure. In Africa, studies by Oga et al. And Ejim et al., which were locally based studies, showed that hypertension was the main risk factor for ventricular arrhythmias. The prevalence of hypertension by systematic review by Adeloye et al. In Nigeria is 32.5%. This high prevalence and high burden of hypertension has led to a high burden of hypertension-related end organ damage at first presentation, which also include ventricular arrhythmias. Ventricular arrhythmias have clinical consequences, especially in hypertensive patients, which can range from heart failure to sudden cardiac death. But the most common complication of hypertension is left ventricular hypertrophy, which is also associated with ventricular arrhythmias. There are other risk factors also in hypertensive patients who can have some risk factors for ventricular arrhythmias, which can range from left ventricular dysfunction to antihypertensive medications. So due to the fact that ventricular arrhythmias have been associated with hypertension and can be a consequence of mortality, this study was to evaluate the frequency and pattern of ventricular arrhythmias in newly diagnosed hypertensive and correlate it to echocardiographic features of structural and functional abnormalities. This was in a resource-constricting environment like Lagos, Nigeria. We wanted to find out what were the markers for high-risk patients and to enhance patient management in places like Lagos and Nigeria. So what is the of this study was using ECG, was to using rest ECG and 24-hour ECG Holter monitoring to explore the relationship with left ventricular structural remodeling, to interrogate the relationship to demographic and clinical parameters. So this study was carried out was a comparative cross-sectional study that was carried out in Lagos University Teaching Hospital in the cardiology and family medicine outpatient clinic. The sampling was convenient sampling, and questionnaires were taken. ECG, echo and 24-hour Holter ECG monitoring was also done. So for data analysis, mean comparison was done for independent t-tests. That mean comparisons was done with independent t-tests. More than 2 means were done with ANOVA. The statistical significance of p-value less than 0.05 was used. So for the patients, for the number of patients that were recruited, 320 subjects were recruited that met the inclusion criteria. Unfortunately, 16 participants had poor Holter ECG recording. So 304 participants were recruited into the study, of which 154 were newly diagnosed hypertensive and 150 were age and sex match controls. So this is a table showing the social demographic parameters of the patients. We can see that they were well age and sex matched. There was also, their marital status also was normal. They were also matched equally. Sorry. Educational status too there was no statistical difference, but there was a significant alcohol consumption that was increased in the hypertensive patients. So from this, we can see that frequency of ventricular arrhythmias in study participants using resting ECG, we can see that only 3 patients of the hypertensive group had ventricular arrhythmias, which made up 1.9% of the patients with hypertension, which was not statistically significant. So for frequency and pattern of ventricular arrhythmias using 24-hour, we can see that 56.5% in hypertensive patients, meanwhile 44.7% were present in controls, which was statistically significant. We can also see that the grading of ventricular arrhythmias that was used was the Long's grading. We can see that there's an increase in frequency of more complex arrhythmias in the hypertensive patients compared to that of the controls. We can see that grade 3 especially was 19.5%, but those in controls were 6%, and grade 4A was 3.9%, meanwhile controls were 2%. Even VPC burden was statistically significant, showing that hypertensive patients had an increased frequency of ventricular arrhythmias compared to controls. So we took it a step further. We now analyzed hypertensives with ventricular arrhythmias. Which one of these patients have left ventricular hypertrophy? So we can see here from this table, from this bar chart, that 87 hypertensive patients had ventricular arrhythmias. But when we came to those who had LVH, about 50 of them had LVH. 50 of them had LVH, making 57.5% of those with ventricular arrhythmias. Hypertension without ventricular arrhythmias were 67. Then when we check for those who had without ventricular arrhythmias without ventricular arrhythmias had LVH, we can see there are only 26, which was 38.8%, showing that hypertensive patients had a higher frequency of ventricular arrhythmias. This was also the same thing that was found in patients with grading of ventricular arrhythmias. We found that the hypertensive patients with LVH had more complex ventricular arrhythmias than those of the control. My sincere apologies. Sorry. Please, I know I have like 4 or 5 more minutes to go, and I'm so sorry. So for the multivariate logistic regression analysis, we had like 3 factors that were statistically that showed independent predictors of ventricular arrhythmias, which were age, educational level, which was non-primary and secondary. So it showed that those with lower educational level had more ventricular arrhythmias. So for a discussion of the results, which is going to be quick, age, the most predominant group of people who had ventricular arrhythmia, who presented with hypertension in this study were 41 to 50, which was similar to the REMA study, Oga et al. In Ilorin, and Adu et al., which are all local studies. As for the alcohol, which I presented, that significant alcohol use was higher in hypertensive group, was similar to Adeke et al., which was also a study that was done on the REMA group. That was 10.8%. Mechanism of action could be increase in sympathetic nervous system and cortisol. Could be a risk factor, or could be a cause of arrhythmias in hypertensive patients, and also hypertension in those patients. So for the 12-lead ECG, I had 1.9% patients, which were only 3 in the hypertensive group. So I have some local studies, Ayola et al. And Ejim et al., which had higher frequencies. And this was because most of the patients in those studies had a shorter duration of diagnosis of hypertension and were not on hypertensive medication. Compared to my study, that I had 58% on hypertensive medication, these 2 studies had untreated hypertensives. For the Holter ECG studies, we have Nessa et al. Compared to Nessa et al., which also played a significant role. Nessa and Pallangyo et al. Pallangyo et al. Had a higher frequency of 82.4%. And this was because these were mostly untreated hypertensives, compared to Nessa et al. That had 80% of the hypertensives that were on treatment. So Malechan et al. And Meseli et al. Had more complex ventricular arrhythmias in hypertensives as seen in my study, which was similar to my study. Echo LVH was associated with ventricular arrhythmias, which was significant to Makrina et al., which is 55%. Chatterjee et al. And Silachi et al. Also had association between complex ventricular arrhythmias and LVH. As for the independent predictors of ventricular arrhythmias, age was an independent predictor, like the Framingham Heart study in my study, showing that maybe age-related fibrosis could be a significant risk factor for ventricular arrhythmias. Low educational status also in my study was associated with ventricular arrhythmias. This could be as a result of, this is a tertiary institution. This was in Lagos State, and most of the patients that were recruited who have low educational status don't have enough money to buy medication. So therefore, they cannot, they were at risk of having ventricular arrhythmias. So in conclusion, frequency of ventricular arrhythmias and complex ventricular arrhythmias using long classification was significantly more common in newly diagnosed hypertensives. Echo LVH was positively associated with presence and pattern of ventricular arrhythmias in newly diagnosed hypertension. Age and low educational status was independently associated with the presence and pattern of arrhythmias in newly diagnosed hypertensives. The final word on this study is that this is one of the few studies that have done a 24-hour, that has evaluated newly diagnosed hypertensive patients in sub-Saharan Africa and in Nigeria with 24-hour Holter monitoring. And it also highlights how important it is for screening of hypertension and also giving hypertensive patients medication. So thank you for listening. I apologize for the interruption again. I'm so sorry. And these are my references. Thank you, everyone.
Okay, great. Thank you, Dr. Enajeroh, for a fantastic presentation. I will now open it up for questions from the judges. If there are any questions for Dr. Enajeroh based on her presentation. We will also monitor the chat.
Yeah, I have a question.
Okay, go ahead.
Dr. Enajeroh, how does this study specifically help you manage your hypertensive patients going forward? Is it going to change any of your management in any way?
All right. Thank you so much for that question. So the birth of this study was actually from one of my patients in clinic who presented with his first presentation was symptomatic ventricular arrhythmias. He didn't even know he was hypertensive, even then, when he came in with symptomatic ventricular arrhythmias. So I thought of this study based on that patient. So I think that this study is going to help, especially when you're thinking about middle-aged patients that have maybe ECG findings, and middle-aged patients that have ECG findings, and you know that they are probably going to have ventricular arrhythmias. This study is going to help point you to those patients that will benefit for 24 hours Holter monitoring in terms of controlling their ventricular arrhythmias. This will also help to propagate, because there are not many studies on ventricular arrhythmias in sub-Saharan Africa. This is going to help to improve. This study can be put forward to show people that there are detrimental effects of hypertension on the heart, even in newly diagnosed patients, and help also with screening of those patients and help for early treatment. So this is going to be one of those studies that can be put forward to see that, to show that even at 1 year of diagnosis, patients already have end organ damage like ventricular arrhythmias already, and can help with screening and treatment. I don't know if that answers your question.
I'm going to follow it up with another question. Are you going to then your older hypertensive patients with LVH, are we going to be recommending doing 24-hour Holters on all of them to look for ventricular arrhythmias?
So I know that's going to be a tricky question. Okay, because that's going to be labor and also financially intensive.
Intensive, right?
So for those type of patients, if they do not have on ECG, I am just postulating that if they do not have on 12-lead ECG ventricular arrhythmias at presentation, I don't think they would benefit from a Holter monitoring in those patients. And those patients would just benefit from going on medication, as we saw from some of these studies, that medication actually helps to improve presence of ventricular arrhythmia in Holter monitoring in those patients. Those patients that had used medication for a longer period of time had less ventricular arrhythmias than those who had used medication for a shorter period of time. So if they're already on medication, I think it would be helpful already to reduce the ventricular arrhythmia without putting them through the hassle of a Holter monitoring, because it's quite laborious for an elderly patient.
Or maybe could follow it up with a study to see if maybe specific treatment of ventricular arrhythmias may be beneficial in decreasing, mortality or morbidity. So, yeah.
I
Okay.
agree. Thank you.
So if I may chime in, great presentation, Dr. Enajeroh. I was wondering, do you have any thoughts about any limitations in this study that you did? What are the limitations?
Okay. So one of the limitations for this study is that it's even a cross-sectional study. Like the doctor that asked me the last question, is a cross-sectional study. It would have been better if there was a follow-up to see if there was actually mortality associated with with those who had more complex ventricular arrhythmias. That's also a shortcoming of this study, number one. Number two, another shortcoming of this study is the fact that the limitations of this study is that, besides it being a cross-sectional study, it's only a few patients that were actually recruited, only 320 patients. On an average, the prevalence of hypertension is very high. So that was still a small sample that was used in this study. That's another limitation of this study. So those are the two limitations I can speak to right now, sir. But there are other limitations of this study. There are.
Dr. Enajeroh, I may have missed it, but was there a certain threshold of either high blood pressure that was associated with more complex ventricular arrhythmias or hypertrophy on the echo, like a certain septal thickness, for example, on the echo? Was there a certain threshold that was associated with more ventricular arrhythmias, if that makes sense?
Sorry, I didn't get your question. Sorry.
I was just wondering in your research, and you may have mentioned it, I may have missed it. Was there a certain threshold for like the degree of hypertension? So for example, were people who were severely hypertensive, maybe above 160, above 180, more likely to have complex ventricular arrhythmias? And you said that also LVH. Was that LVH? I think it was based on echo that you mentioned, ultrasound, right? Was there a certain threshold for the degree of LVH, like the thickness, like greater than 1.5 centimeters for the septum? Did you find sort of gradations there, or thresholds that were associated with more malignant ventricular arrhythmias?
All right, thank you so much for the question. When we evaluated blood pressure ranges, because we got blood pressure from all the patients, that's not in this data here, but it's in my analysis. When we got blood pressure ranges, unfortunately, there was no correlation between that and complex ventricular arrhythmias. As for the left ventricular hypertrophy, we used wall thickness of 1.1. Thicker than that. That's when we started thinking about left ventricular hypertrophy. We also graded the left ventricular hypertrophy also, which was not also added in this data. We talked about left ventricular remodeling, hypertrophy, and eccentric left ventricular hypertrophy. Unfortunately, with that result, when we tried to correlate malignant arrhythmias to those particular types of left ventricular hypertrophy, it was not statistically significant. So, yeah. So the only thing we found that was statistically was LAVI. Even diastolic dysfunction was not.
Maybe I can just chip in there briefly. This lack of statistical significance, could it have been that your study was not powered to show that? Did you work out the statistics to ensure that you are able to demonstrate these correlations?
That's an excellent observation. I don't think I powered my study to even answer that question in the first place. It was just LVH that it was powered to answer that particular question. So thank you for that observation. I wasn't powered to answer that question, sir.
Okay, are there any other questions for Dr. Enajeroh? If not, then we'll move on to our next presenter. Okay, thank you, Dr. Enajeroh. Great job. Wonderful presentation.
Thank you. I'm so sorry again.
No worries. Okay, great. And so next we'll have our presentation, and the title is Survival Prospects of Women. Keep the timer there. Okay. Survival Prospects of Women with Peripartum Cardiomyopathy, a prospective cohort study, which will be presented by Dr. Pedro Pallangyo from Jakaya Kikwete Cardiac Institute from Dar es Salaam, Tanzania.
Thank you very much. Hello, everybody. Greetings from Tanzania. I'm delighted to share with you the presentation of our ongoing study on peripartum cardiomyopathy in Tanzania. I have no disclosures. So heart failure in pregnancy is a common phenomenon, and although it affects just about 4% of pregnancies, but it's estimated to cause around a third of all maternal mortalities globally. In other words, cardiovascular disease is a single most lethal risk factor in pregnancy. And unfortunately, Black race is included as amongst the indicators of poor prognosis. This particular slide displays maternal health in Tanzania. And as we stand, the global target as far as maternal mortality rate is concerned is to reach less than 70 deaths per 100,000 live births. In Tanzania, we have had a steady reduction of maternal mortalities from around 900 plus in the 1990s to around 104, which is our current figure, still way above the global target as we speak. Sub-Saharan Africa, on the other hand, has the worst maternal mortality rates with the regional rate of around 531 per 100,000 live births. Comparing Tanzania, the world, and Sub-Saharan Africa, we lie somewhere in between, so still we have some work to do. Tanzania has a population of over 60 million individuals, and women of reproductive age constitute around a quarter of our population. The four traditional causes of maternal mortalities still remain the leading ones. That includes eclampsia, obstetric hemorrhage, maternal sepsis, anemia. However, amongst the indirect causes of maternal mortality, cardiovascular disease is the leading cause, claiming around 14%. This particular slide aims to to show a contrast between the incidence of peripartum cardiomyopathy and maternal mortality. And the clear picture here, or the message here, is that populations where there is high incidence of of peripartum cardiomyopathy, it coincides with high rates of maternal mortalities. And as we speak, the sub-Saharan Africa has the highest rates of peripartum cardiomyopathy, and in that line, the highest maternal-related mortalities to peripartum cardiomyopathy. So why did we decide to care? So we have observed high morbid mortality amongst the women in our clinical setting, and this is accompanied by high healthcare costs to treat this potentially curable condition. But most importantly, reducing maternal mortality is in line with our SDG goal number 3. So this particular study aimed to explore survival and prognostic factors among women with peripartum cardiomyopathy in Tanzania. We defined peripartum cardiomyopathy according to the ESC and AHI guidelines. We started this study in 2016. It's still ongoing. It's a prospective study. We initially started with one site, that was the National Hospital, the National Cardiac Hospital where I work. But later we expanded to include 6 other regions, so a total of 7 regions, 7 sites, excuse me, as we speak. We had 3 primary outcomes, that's maternal mortality, complete recovery, and persistent LV dysfunction. And we had a couple of secondary outcomes, including thromboembolic events, infant mortality, subsequent pregnancies, and rehospitalization. This particular slide displays the clinical demographic characteristics of our participants. So far, we've managed to enroll around 1,445 individuals, potentially one of the highest or the largest cohort of women with peripartum cardiomyopathy in the world. The mean age is around 29 years. Our participants actually came literally from all the 31 regions of Tanzania, which actually implies that this is not a regional sort of a problem. A large majority of participants had attained primary education is the highest level. A very small proportion had health insurance. So this was a socially disadvantaged subpopulation, if I'm to put it that way. Regarding the ECG, sinus tachycardia was the most common rhythm, and atrial fibrillation was observed in around 13% of individuals. As per echo, around 42%, 43 had EF of less than 30%, which signifies severe systolic dysfunction. Hypertension and anemia were the leading comorbidities during pregnancy amongst these women. So this slide displays the clinical endpoints, and after an average of 944 days of follow-up, so that's about just over 2.5 years, this is what we've observed. So we've observed an infant mortality rate of around 23.4, so just close to a quarter. Thromboembolic events in just over 11%. Regarding the 3 primary outcomes amongst the women with peripartum cardiomyopathy, our recovery rates are just around 27%, with persistent LV dysfunction of around 44% and mortality rates of just over 29%. This slide aims to compare the timing between recovery and mortality. As the literature says, in Black populations, the recovery actually comes quite late, and majority of our women actually attained recovery after 2 years of follow-up, while regarding mortality, majority of our women died between 3 months and 1 year. Regarding timing of diagnosis and GDMT uptake, delayed diagnosis, which we defined as diagnosis reached over 3 months of clinical or symptom presentation, was observed in close to 34%. So just over a third of our women had delayed diagnosis. And looking at the bar graph on the left, there were significant negative outcomes that includes persistent dysfunction and death amongst women with delayed diagnosis compared to those whose diagnosis was timely. The bar graph on the right displays the guideline-directed medical therapy. Overall, suboptimal GDMT was observed in 57% of all women. Diuretics was observed as the most prescribed anti-failure drug, and particularly upcountry, so outside Dar es Salaam, where the cardiac center is, majority of patients who are referred to us were actually on diuretics as a single drug. And again, comparing guideline-directed medical therapy with mortality, there was significant differences, with mortality higher amongst those who received suboptimal GDMT compared to those who were optimized on GDMT. We had observed subsequent pregnancies in 183 women, a total of 284 subsequent pregnancies. And here I've summarized the outcomes. We have observed 58.1% worsening in cardiac functions in these women. There was a 51% relapse, recovery rates of around 46% and 12% mortality. We also observed an interesting phenomenon of spontaneous relapse, and this is amongst women who had attained recovery without any traditional or understood obvious stressor, but still they had decline in cardiac functions at various points in time. In our cohort so far, we've observed this in 10 women. This particular slide displays predictors of maternal mortality, and here we ran a logistic regression analysis. Our model had around 17 potential variables. During bivariate analysis, 12 of these showed significance. However, after controlling for confounders during a multivariate regression analysis, delayed diagnosis, suboptimal GDMT, presence of atrial fibrillation, left ventricular internal diameter of over 60, which signifies severe left ventricular dilatation, EF of less than 30, which signifies severe systolic dysfunctions, subset of less than 14, which signifies severe right ventricular dysfunction, and presence of LV thrombus were found to be independent predictors of mortality. So this particular slide displays barriers to effective peripartum cardiomyopathy care. And actually here we've focused on the modifiable factors, which includes 3 levels in general. So the facility level, the provider level, and the community level where these women reside. So just to conclude my talk, peripartum cardiomyopathy presents quite late in Tanzania. There is a high frequency of suboptimal GDMT, which results in high morbidity and mortality amongst these women. The subsequent pregnancies have clearly shown that it's regardless of whether these women have attained recovery or not, it's still risky to have pregnancy again amongst these women. And as far as what this implies for practice, this particular study calls for community-based interventions as well as healthcare facility interventions to empower these healthcare professionals, one, on the diagnostic capability of cardiac diseases. It's quite interesting that our government has actually invested a lot in putting echoes in all the regional hospitals, but the component of building capacity to the resident workers was actually overlooked. Given the negative outcomes that we have seen, we have also observed that follow-up of women with peripartum cardiomyopathy should not end when they attain recovery, because there are a lot of other things like relapse which could actually come up. So as far as our next steps is concerned, just to wind up, we are currently planning to do what we call a Save Mama initiative. And Save Mama stands for Strategic Approaches Towards Eliminating Peripartum Cardiomyopathy in Tanzania. This project aims exactly what I've just said as the next plans or next steps. is to build capacity at all the regional hospitals where these women will be referred to, but also have community projects to empower and raise awareness amongst these women. But also we are interested in conducting both immunological and genetic studies to further characterize and understand the drivers of this particular disease in our communities. With those remarks, I would like to end there. That's the team we've been working with. Thank you very much for listening.
Okay. Yeah, thanks, Dr. Pallangyo. Wonderful presentation. So the presentation is now open to the judges for questions.
Hi, sure. Dr. Pallangyo, sorry, maybe modeling your name. I'm particularly interested in your question on, in your slide on relapse in patients who had repeat pregnancies, and how those numbers played out. So you said a 58% relapse, but then you also said a 51% recovery. So just trying to clarify in my mind, how do women do with repeat pregnancies after peripartum cardiomyopathy? That particular slide is what I'm particularly interested in.
I didn't get the question, I'm sorry. Can you come again?
I don't know if you want to share your slides and go back to the one, but I'm asking specifically about outcome of women who have repeat pregnancies after peripartum cardiomyopathy, because I wasn't clear on your numbers there.
Right, just a second. I would like to share this again.
If I may add to that. So this is what is the impact of additional pregnancies after the incident?
So in our cohort, aside from the women who unfortunately died, so amongst the survivors, we had divided them into two groups in this particular analysis. So there are those who decided to, well, get pregnant again while still they were having persistent LV dysfunction. And then we have a second group of those who had attained echocardiography recovery and then decided to conceive again. So amongst those who decided to conceive again, who were in group number 2, then we have those who had LV dysfunction recurring again. So that's relapse. So for example, they had already attained an EF of 71, for example. And then during this second pregnancy, they presented again with features of heart failure. EF was reduced around 35, around 40%. So that is what we called relapse. Mm-hmm. But then in group 1, for example, they conceived again while they had an EF of 45. So they had not attained recovery yet, but then during the second pregnancy, the EF dropped to 25. So that's worsening of heart functions. That's how we put it. And then we have the ones who recovered now after this, and then the ones who died. So those are the 4 outcomes as we have put.
Right. So what are you advising your patients based on these numbers?
Right. So based on these numbers.
Yeah, I'm one of these patients. What are you going to tell me about a subsequent pregnancy?
Right. So regardless of whether you have attained recovery or you're still in LV dysfunction, you are at risk. However, comparatively, the women who had attained recovery were better off as far as mortality is concerned. Mortality was actually twice as much amongst those who conceived again while they had LV dysfunction compared to those who had attained recovery. But nevertheless, the risk is still there.
Right. Okay.
So if I may add a follow-up to that question. So now the individuals who relapse, or the so-called spontaneous relapse? Were they on medications? Did they continue to be on GDMT when they relapsed, or did they stop their GDMT?
Interesting. So of the 10 women that we've reported, 3 still continued to be on GDMT, and 7 were actually lost to follow-up after some time, ranging between 3 months post-attaining recovery up to 2 years. So there are women who continued to use medications for 2 years, but then because they had no symptoms, we had lost them to follow-up, but then reappeared with symptoms of failure a year after, 2 years after, up to 3 years. So there is a variable presentation, but it's a mixed group. Still, we have 3 women out of those 10 who were still on GDMT, did not conceive again. There were no any clear stressors, but still they had decline of cardiac functions, and that's what we called spontaneous relapse. Yes.
Thank you. Any more questions for Pedro?
I
There's
have
a question in the chat, actually. Oh, yeah.
Right.
Okay, so my question is similar to the one in the chat, and there are 2. So one, and you may have touched on this, when these women are first diagnosed, who is diagnosing them? Is it, like, or where are they presenting first? Because it seems like there's a lot of misdiagnosis, which is quite common. And so are there any sort of educational initiatives that can happen there? Another question about the GDMT is, how much of that do you think is lack of education and some concern around lactation and breastfeeding, and some concern of toxicity of the medications, which could be mitigated by education, right? So that kind of goes to the question in the chat, like what sort of community level interventions or educational initiatives can be done to improve detection and to decrease misdiagnosis, and then to improve GDMT prescribing and adherence. And then my last question is, did you see, are there certain risk factors that are highly prevalent in Tanzania that may contribute to the high rate, right? Any sort of, I've heard that sometimes that in Nigeria, there was some thought that it was due to some diet, like high salt diet, or, are there very high rates of preeclampsia? Is it common for women to have like multi-gestations, like frequency of twins or triplet, is there something that's common that may contribute to the relatively high incidence of peripartum cardiomyopathy?
Thank you very much for very good questions. If I might start with the last one. So regarding risk factors, we've observed quite a number. So one being very high rates of preeclampsia. In our cohort, the rates of preeclampsia are close to 50%. So that's one. But also, we've observed twin pregnancy rates of around 20% in our cohort, which I would say is relatively high. But also the parity average amongst our women is quite high. So the mean average is around 5 kids, and we have around 11% of these women having between 8 and 12 children. So those quickly I would point out to be the risk factors, but also definitely nutrition plays a role. Although we did not go deep into nutrition in this particular cohort, but it's something we hope to add on in our ongoing cohort. As far as GDMT is concerned, the main challenge here is that education, I would say, certainly. Majority of the regional hospitals lack either cardiologist or physician, and that plays a major role. And that's why when these women present first and they are met or seen by a GP, then Lasix furosemide appears to be the only drug that is prescribed. And most women will be told that, well, these are just normal pregnancy-related symptoms. And so until they reach us as a tertiary care level hospital, it's usually late. And we have received women who have have had symptoms for over a year, and still the diagnosis had not been reached. As far as where the diagnosis, or where are these women diagnosed, majority of these women present first in their district hospitals, and that's how our health hierarchy is like. So after presenting at the district hospital, where at this point they are largely seen by who we call clinical officers or assistant medical officers, which basically have a diploma in medicine. So a lot of time is being wasted here. But for the women who present with severe symptoms, then it warrants them to be referred to the regional hospitals. And as I've said earlier, the regional hospitals in the whole country are equipped with echo machine, but the training of the resident workers there to manage these echo machines has not been done, unfortunately. And this is where we want to build from here, that we have physicians there and other workers who we could do some echo training and build capacity to them, as well as enlightening them on GDMT, so that when they diagnose these women, they can initiate the correct drugs.
Thank you.
So,
Thank you.
one more question for me. Given your experience so far, what would you say is your biggest challenge in conducting this research or similar research in Tanzania? What would you say is one or two of your biggest obstacles or challenge?
One of the biggest obstacles was building a team with similar interests. That I'll put first. For the first 3 years, well, people didn't think that this was something worth doing, simply because of its rarity. But then slowly I started building a team, and then adding other centers from the main hospital was also a bit challenging, because one thing I must admit is that the research culture, and this is similar to other African countries, I think, is still on the lower end, because most people focus on the clinical practice and they think that's where money is. But we must come out with evidence-based and data-driven info from our own end. And I would say that is something I really wish to change. And that is what I would point out as a major obstacle that I've seen.
Yeah. Thank you very much for that wonderful presentation.
Pleasure. Thank you so much.
Yeah. So we will go to our final presenter today, the last but not the least. This is going to be, the topic is on diagnostic accuracy of resting electrocardiogram in detecting left ventricular diastolic dysfunction in normotensive diabetic subjects. And the presenter is Dr. Mohammed Sani Abubakar from the Federal Teaching Hospital, Komba in Nigeria. Dr. Abubakar, over to you.
Thank you. Okay, thank you very much. So I'll follow this outline for the presentation. I will discuss the brief background and justify why this study was carried out and the aims and objectives, and the method we use and what we found, and implications and next steps regarding these findings, and then I will answer some questions. So left ventricular diastolic dysfunction is an impairment of left ventricular filling, relaxation, or compliance. And it is a precursor to several cardiac diseases. And diabetes mellitus, being one of the major risk factors for cardiac disease, is associated with a lot of morbidity and mortality. And the majority of these patients die from cardiac diseases, including cardiomyopathy. And the most common abnormality observed in this patient is asymptomatic left ventricular diastolic dysfunction. And the gold standard for diagnosis of left ventricular diastolic dysfunction is echocardiography. So while the technology for of echocardiography continue to evolve in high-income countries, low-income countries are trying to provide this vital tool to most vulnerable and poor resource populations. So its inaccessibility makes it difficult to diagnose this patient. and it creates a critical gap in detecting these patients. And diabetic normotensive patients are unlikely to see cardiac patient cardiologists. So this predisposes them to late presentation. So the hallmark of diabetic cardiomyopathy, like I mentioned, is left ventricular diastolic dysfunction. And because of the critical gap that exists in detecting this disease entity, the current diagnostic tool is inaccessible, and normotensive diabetic patients usually focus on management of their blood sugar, so they are less likely to be subjected to this rigorous cardiac assessment without overt cardiac symptoms, which may be late at that time. So this study directly addresses this urgent clinical need, validating a cost-effective ECG-based screening tool, so thereby paving way for earlier diagnosis and improve patient outcome, especially in resource-limited settings. So the main aim is to assess diagnostic utility of POF dispersion, QTC, and T50-TN interval for preclinical diagnosis of left ventricular diastolic dysfunction. And there are 4 specific objectives. One is to assess the sensitivity of these parameters, and then the second is to assess their specificities, and also to assess their predictive values. And then the fourth specific objective is to assess their diagnostic utility when these parameters are combined. So it was a cross-sectional observational study conducted over 8 months period at the University of Abuja Teaching Hospital, Nigeria, where we recruited 184 normotensive diabetic patients. And detailed clinical data, including the anthropometry, drug history, were recorded. We performed a comprehensive echocardiography as our gold standard for diagnosis of left ventricular diastolic dysfunction. And this patient had 12-lead resting ECG recorded. And individuals aged more than 18 years and above who consented for the research and were normotensive diabetic, never been on medications, were enrolled for this study. And then ECG features of atrial fibrillation, frequent arrhythmias, or those with systolic dysfunction or indeterminate diastolic dysfunction, valvular heart disease, heart failure, hypokalemia, CKD, or QT prolonging medications were the exclusion criteria used in this study. So these were the equipments we use. We use Vivid E95 echocardiography, and then cardiac ECG. So that was connected to HP laptop installed with the cardiac device. So other equipments include the BP apparatus, and then other device for measurement of anthropometry of the patients. So our primary focus was to evaluate the diagnostic accuracy of POF dispersion, QTC, and T50-TN interval, and a robust statistical method, including receiver operator characteristics, was done to detect optimal cutoff values for these parameters. So for the echocardiographic assessment, we used the 2016 American College of Echocardiography criteria for diagnosis of left ventricular diastolic dysfunction in subject with normal ejection fraction. And there are 4 parameters there: the septal E prime less than 7, or lateral E prime less than 10, average E over E prime of more than 18, left atrial volume index of more than 34 centimeter centimeter per meter square, and then tricuspid regurgitant peak velocity of more than 2.8 meter per second. So subjects that have more than 2 negative criteria were classified as normal diastolic function. Those that have 2 were indeterminate, and those that have more than 2 positive were left ventricular, categorized as those that had left ventricular diastolic dysfunction. So the electrocardiogram of each patient was exported via PD8 in a portable disk format using an export module of the cardiac device. And then each ECG was magnified to 25 by 20 millivolts, and then zoomed to clearly identify the ECG waves for clear measurement. So POF dispersion is the difference between the maximum, that is the widest, and the smallest POF. And PUF has to be visible in most of the leads qualified for analysis, and also there has to be absence of overwhelming arrhythmias. So we use PUF dispersion of more than 33.46 milliseconds as prolonged based on meta-analysis studies of PUF dispersion. So for the QTC, it was measured from the beginning of the Q wave to the end of T wave, and rate-corrected QTC was also calculated, and we used values greater than 440 milliseconds or 450 milliseconds were considered prolonged in male and female respectively. So for the T peak to Tn, it was measured from the peak of the T wave to the end of the T wave, and we commonly use V5, but where the V5 wasn't suitable for analysis, other leads were considered, such as V4 or V6, and value greater than 89.4 milliseconds was also considered prolonged. So this is a flow chart of how we recruited the patients. 275 patients were recruited, out of which 35 were excluded due to pregnancy, hypokalemia, and LV systolic dysfunction. And then out of the 240 enrolled patients, 11 patients had incomplete or low quality data. And then out of the 229 patients with complete data, 445 patients were excluded due to indeterminate left ventricular diastolic dysfunction, because it's difficult to analyze sensitivity and specificity when you use the three categories of patients. So it has to be positive and negative. So the those with indeterminate diastolic dysfunction were excluded, and 184 patients were analyzed for sensitivity and specificity. So this table is showing the relationship between the echocardiographic parameters in those with normal diastolic function and those with abnormal diastolic function. Difference in those with normal diastolic function and those with abnormal diastolic function. So this table is a binary logistic regression that is showing association of the ECG parameters for left ventricular diastolic dysfunction compared to echo features of the diastolic dysfunction. And you can see that PUF dispersion and QTC were respectively having 7% and 2% increased odds of having left ventricular diastolic dysfunction, and this increase remains significant despite adjustment for age, sex, and mean arterial blood pressure. So for internal validity, because this page data were measured manually, so we conducted repeatability and feasibility analysis where 30 patients were selected randomly, and the patient had their values remeasured while blended with the first reading. And you can see that all the parameters have intra-class correlation coefficient of more than 75%, which represent excellent intra-observer reproducibility and also good repeatability when you look at the Komba's alpha and Bland-Altman's plots. So this table is showing the diagnostic accuracy of these ECG parameters as calculated using this formula. And you can see that PUF dispersion has the highest sensitivity with sensitivity of 97% and a specificity of 41%. And it has highest negative predictive value of 96%. However, QTC has higher specificity of 63% and sensitivity of 73%. So the TPTN has lowest diagnostic utility. You can see the sensitivity is 51% and specificity is 59%. So when these parameters were combined, combination of PUF dispersion and QTC has the highest diagnostic utility. Looking at the sensitivity and specificity, this specificity is 73%, sensitivity is 70%, while the negative predictive value is 82%. However, combination of all the three parameters, PUF dispersion, TP to TN, and QTC, increased the specificity to 85% and sensitivity. However, the sensitivity dropped to 40%. So this is a receiver operator characteristics that is trying to show the discriminating ability of a diagnostic tool. So for a diagnostic tool to be, the receiver operated characteristics, the closer the area under the curve to 1, and also the p-value, the better the diagnostic utility. It is a plot of sensitivity against false positive rate. So a good diagnostic tool should have high sensitivity and low false positive rate. So if you look at this curve, you will see that the PUF dispersion has an area under the curve of 0.78 with a significant p-value of less than 0.001. And then for the QTC, the area under the curve is also significant, 0.65 with a p-value of less than 0.009. However, in the TP to TN, the area under the curve is 0.54, and the p-value is not significant. This is just showing the combination of all the curves in the graph. So, and then, so heat maps is to just look at the diagnostic ability of these tools using various thresholds, bearing in mind the sensitivity, the specificity, and Yodens index, which is the sensitivity, specificity, and then false negative rate. So if you look at it, PUF dispersion at 40 has the sensitivity of 97%, just like I presented, specificity of 40. However, if you increase the cutoff to 60%, the sensitivity is 75, specificity is 69. So the specificity increases and the Yodens index is higher, which is 44. So this could be better. So also in QTC, which is 460, and also the TP to TN at value of 90 milliseconds. So for the, what is the conclusion? So we concluded that our study demonstrated that resting ECG parameters are promising and accessible, cost-effective tool for preclinical diagnosis of left ventricular diastolic dysfunction in Nigerian normotensive diabetic patients. And this breakthrough has the potential to impact cause increase in early screening strategies, leading to timely intervention and then reduction in morbidity and mortality associated with this condition, especially in our area of where we have limited facilities. So we recommend that, so we have followed the following recommendations. Our findings strongly support integration of ECG screening in routine care for normotensive diabetic patients in the low risk settings. These patients, we know that echocardiography require a lot of skills and it's not readily available. ECG is easier to perform and it's cheap. So if we can integrate it in routine screening for patients with normotensive diabetes that are less likely to see cardiologists, we can be able to pick these patients early and act appropriately. And also, based on our findings, we realized that 89.1% of these patients have their minimum PUF in AVL, and 92.4% have their maximum PUF and in the 2. So we suggest that AVL and the 2 should be used as the smallest and widest PUF respectively to determine PUF dispersion, because it's cumbersome to estimate the PUF in all 12-lead ECGs with difficult. So if you can use this, it's also a recommendation. While for the QTC, a majority of patients, about 62.5%, have their QTC in V3, followed by V4 and V5. So this study is a cross-sectional study, so longitudinal study to confirm causality and also long-term outcome is also a recommendation that should be considered. So what are the limitations? Number one, it is a cross-sectional study, so future longitudinal studies is required to determine the causality and track long-term outcomes. Another limitation is that this we use office blood pressure to recruit this patient, so ambulatory blood pressure was not used. So patients with mass hypertension might have been enrolled in this patient. So So that's another limitation. Then another limitation is that these parameters, particularly the ECG, are measured manually, which are prone to error. However, reproducibility and repeatability analysis revealed excellent intra-class correlation and good observer reproducibility. So how does this research contribute to knowledge? These studies among the first systematically evaluate the diagnostic accuracy of these specific ECG parameters for preclinical diagnosis of left ventricular diastolic dysfunction. So in sub-Saharan African population, and thereby filling a significant gap in global cardiovascular health research. So future research, there is need to validate these findings in a large multi-center cohorts, and also developing a predictive model for left ventricular diastolic dysfunction risk and assessing the impact of early intervention using ECG as a screening and also observing the outcomes after intervention. Then use of artificial intelligence also is also important to recognize ECG features of
I think we lost Dr. Abubakar. Can everyone hear me?
Yeah, in fact,
Yes.
I was wondering whether it was at my end, but we've lost him.
Yeah. So I think we're at the end, so I don't know if Dr. Haynes can take over now for Q&A.
There was one question in one hand was raised from the chat. I don't know if Dr. Collins would like to raise that question now.
Hi, colleagues. Can you hear me?
Yes. Yes. Thank you for coming back.
Sure. So
Sorry,
apologies. I'm actually in traffic driving, but first of all, congratulations to the speaker for what I thought is an excellent presentation for two main reasons. One, yes, it does add or kind of a diagnostic tool for left ventricular diastolic dysfunction, but more importantly, it's even more important in resource-limited countries. Now, I noticed that the last slide, the comment was made about the use of artificial intelligence and some of the data that could be used as a predictive model. I just wanted to caution the presenter, maybe we shouldn't be so narrow-minded in what are the predictors we think, and use a big data model with several possible predictors, including geographical location and socioeconomic status, because then we get a more robust predictive model. So I'm excited to see how AI will further improve the sensitivity and specificity of the use of the ECG. So congratulations again. I look forward to part B of these results.
Thank you.
Do any of the judges have any further questions?
No, I just want to congratulate the presenter on such a comprehensive work, tedious, I think, in some ways, but I think he did go over some of the limitations, and but I also wanted to ask about right now, what are the practical changes that he is making in his practice as he sees patients based on the results of this study?
Thank you very much for the question. So like I mentioned during the presentation, these patients that are diabetic, normotensive, usually focus on management of their blood sugar. And you can see the prevalence, the percentage, majority of them die from cardiac related complications, including cardiomyopathy, and it's usually asymptomatic. So with this study, I want it to be incorporated in management of patients as a screening tool for these normotensive diabetic patients that are less likely to see cardiologists, so that if they have these ECG features, they should be referred to centers where they will have their echocardiography assessed and also assess other risk factors and manage appropriately to prevent progression and then other complications. I hope that answers the question, sir.
May I follow up on that? Yes, Dr. Abubakar, thank you for a very good study and very exciting, findings. But maybe being the devil's advocate here, the idea is to make this a screening tool to screen people who can then be, referred for echo. But I'm looking at the detailed analysis of the ECG that is, was done manually. And in most African countries, that would have to be done manually. In the context of a busy clinic, busy clinicians who are short of time. What do you see as the practicability, despite the very obvious scientific excitement? What do you see as the practicability of doing this in real life, clinical practice?
Sir, thank you. It's actually difficult, like I mentioned, but that is why in the course of study, we went ahead to look at the ECGs that have predominant maximum P wave and also the minimum P wave, since the P wave dispersion has the highest diagnostic.
Looks like Dr. Abubakar is experiencing some technical difficulties.
Am I audible?
Yes, now.
Okay, so and see what is the diagnostic utility when these two leads are used. So that will make it easy for clinicians to just look at these two leads and then find out whether this patient is at risk and then go ahead with the echocardiography and other clinical assessment.
Great, thank you very much. I think we should move forward, and I'd like to now really thank and introduce our judges for today's abstract competition. They're Dr. Agola, Dr. Anwami, and Dr. Haynes, and Dr. Scantleberry. They'll now be transferred into a breakout room to discuss the presentations and do the scoring. And I would now like to just thank all of our abstract finalists for their outstanding presentations today. This was an exceptional job, not only just showcasing the depth and quality of your research, but also the passion and promise you each bring to the field. As our judges go to the breakout room to deliberate, it'll be my pleasure to add to the stage Dr. Anthony Fletcher, again, our president, as well as our founder, Dr. Richard Allen Williams. Thank you very much.
Thank you very much, Dr. Underwood. And good morning, everyone. I'm Dr. Anthony Fletcher. I'm an interventional cardiologist with CHI St. Vincent's in Little Rock, Arkansas, and I'm privileged to be the president of the Association of Black Cardiologists. What an inspiring program it's been so far. I want to begin by expressing my deep gratitude to all today's presenters. Your work truly reflects the excellence and innovation we strive to uplift within the ABC community. We now shift to a very special part of our program, and for the next 15 minutes, we want to take time for reflection and connection. This fireside chat is an opportunity to look back on how far we've came as an organization, as a community, and as a movement, and to look ahead with renewed sense of purpose and possibility. It's my honor to introduce two pillars of the Association of Black Cardiologists. You've had the opportunity to meet Dr. Paul Underwood, our board chair, and it is my esteemed pleasure to introduce our founder, the Honorable Dr. Richard Allen Williams. Their leadership, vision, and unwavering commitment have shaped the foundation of ABC and continue to guide us forward. I invite you to listen with intention, reflect with pride, and engage with hope, because the story of ABC is still being written, and we all have a role in what comes next. For the next few minutes, we're going to have a discussion with my esteemed panelists around three questions. The first will be looking back and looking forward. Dr. Williams, as the founder of ABC, and Dr. Underwood, as our current chairman of the board, how do you see ABC's evolution from its founding to today? And what excites you most about the organization's future, especially with the global initiatives like this inaugural competition we've witnessed today? Dr. Williams?
Well, first of all, thank you very much for having me on. I appreciate the opportunity to make some very brief comments about this program and about ABC in general. As the founder of ABC, I'm particularly proud to do this. I would like first to give congratulations to Dr. Onwani for the initiative that he has taken in starting this enlargement and expansion of ABC's purposes to bring better health care, cardiovascular care, not only locally, so to speak, or regionally, but globally. This is the purpose of having this program, the J. Brown International Abstract Competition, which gives some expanded purpose to what we are attempting to achieve in ABC. Now, as it's said, the past is prologue, and going back very briefly to the past, we have to acknowledge the fact that ABC is witnessing its 50th anniversary, and I'm sure Dr. Fletcher will be talking more about that, and Dr. Underwood, as we move forward. In this 50th anniversary, it is propitious that we're expanding our program internationally and making this global outreach to bring even wider aspects of cardiovascular care to the entire globe, and especially to those areas in critical need of our attention.
Dr. Underwood, would you like to share?
Well, I think certainly Dr. Williams really succinctly summed everything up. From my perspective, I see that over time, there certainly has become more of an awareness of the impact of cardiovascular disease on people of African descent, and particularly here in the United States. And we see now all over the world that cardiovascular disease is a major nemesis for our people. Understanding how we can expand our efforts in all directions, whether it's going to be through research, through education, and creating more providers to go out and treat the illnesses, if we have to go into communities and doing community education, and then also advocating for assistance from our government agencies to improve the care of all people, has been an important component of ABC that has only expanded over time, over the 50 years. And now we have a platform that we can create more leaders, just as we're doing here with our international abstract competition, to enter the field to be important players in taking care and controlling cardiac disease.
Thank you. Yeah, I think it's exciting that we embrace our global partners as we move forward in this general direction of eradicating cardiovascular disease globally. The second question will address the global cardiovascular disparities. Cardiovascular disease continues to disproportionately affect communities of African descent worldwide. How can organizations like ABC best collaborate across the borders to address global inequities in prevention, access, and care? Dr. Underwood, we'll start with you with that question.
Well, I think the first thing is what we're doing now is expanding our focus away from looking at solely the United States and understanding the diaspora that we have all been in. Certainly, we've known of coming to the U.S. through the Caribbean to America, but now it's possible for us to reach back, and we're trying to establish networks that we can then have projects. This being a very good first project, definitely, but to expand from here on other aspects of cardiovascular care, cardiovascular health amongst all of our partners.
Dr. Williams, would you like to make some comments about addressing global cardiovascular disparities?
Well, I think the term partnership is key in what we're considering here. And at the outset of the program, it was mentioned that we've established a partnership in regards to this particular program today with a number of societies throughout the diaspora. This is extremely significant. It's the first time that this has happened, and it gives ABC a chance to provide a critical outreach to areas of need, which have been there but have not been addressed before. So I think we're in a new paradigm, which gives us an opportunity to provide even greater outreach and touch even more lives in regards to what ABC's purpose is to uplift cardiovascular care for all humanity.
Thank you, Dr. Williams. Our third question will kind of work around advice for emerging leaders. What guidance would you offer to early career researchers and clinicians like our finalists today, who are obviously committed to advancing health equity and transforming cardiovascular care through their work? Dr. Williams, what would you advise our young upcoming stars that we're having the opportunity to hear a sample of today?
Well, first of all, I'm impressed by their facility that they've already developed as young researchers in carrying out their projects and reaching further into the woods, so to speak, regarding their areas of interest. I think it's important, as I mentioned, the past is prologue, to go back to the past, to look at the researchers that have been there and done some of this before. I particularly refer to the last presenter, for instance, Dr. Abubakar, who focused on looking at the ECG and the possibility of taking some features of the ECG and utilizing that for purposes of diagnosing left ventricular disease that is normally accessed through echo, but is not that accessible in certain areas of the world because of a lack of instrumentation availability. So in any event, to cut to the chase on this, I think, for instance, Dr. Abubakar might look at the work that some of the members of ABC has done in the past, have done in the past, and especially in regards to research on P waves and atrial abnormalities and ECG and so forth. And I think that he might find some interesting correlations there. The same is true in the study that one of the presenters did on hypertension and left ventricular hypertrophy. Particularly, that would be interesting if she would be able to go back and look at the research that was done by Dr. Dan Savage, who is one of our early presidents of the ABC and an important researcher on LVH and on echocardiography. So in other words, like I said, the past is prologue. If we go back and look at some of the things that have been done before, we can learn some valuable lessons that could be applicable to their research in the future.
Dr. Underwood.
Absolutely. I certainly agree with Dr. Williams. I was very pleased with the abstracts to see how it really encompasses a lot of the activities that ABC is involved in. And I would really like to encourage the presenters to maintain their academic pursuits and to be involved with ABC. We discussed clinical manifestations, We discussed the science and research and newer, even AI models that can be used to help control cardiovascular disease. We heard a little bit about policy initiatives, particularly governmental initiatives that have taken place to address the issue, as well as community and professional education. So these are aspects that ABC really encompasses, and I really want to congratulate you all and encourage you to continue to pursue your academic pursuits as well as your clinical pursuits.
Thank you for those comments. I find it very interesting.
Just one thing that I forgot to mention. Dr. Julian Haywood is the ABC predecessor who did so much work on the electrocardiogram and the P wave. Yeah. And I would certainly encourage Dr. Abubakar, if he hasn't already, to take a look at Dr. Haywood's work. Sorry.
Thank you. Thank you. No, thank you for that historic update. Certainly, ABC has been rich in tradition and the depth of science and research that our members have contributed to the body of cardiovascular disease. And I find it pretty interesting, when you listen to our presenters overall, they encompass a lot of the general basic concerns and issues. They talk about cardiovascular deserts that we are certainly looking into in this country. They talk a little bit about the social determinants of health in terms of education and resources and nutrition and transportation and lack of access to care. So I think these four presenters have certainly embodied a lot of the concerns and the issues that we look at ABC. I want to thank you, Dr. Underwood and Dr. Williams, for such a rich and meaningful conversation. Your reflection not only reminds us of how far we've come, but the challenges, and inspire us to push forward. This dialogue was a powerful reminder that the work we do today is built on the legacy of courage, excellence, and advocacy. And it's our responsibility to continue that work with every, even a greater purpose, and even reaching out to our international partners. I thank you to everyone who joined us for this important conversation. Your presence and engagement are what make ABC the community that it is. And by this, we're even stronger. At this time, I'd like to turn the program back over, I believe, to Dr. Underwood or Dr. Haynes, if she's back with us, to close us out. And thank you again for the opportunity to be part of today's tremendous program. I look forward to many, many great programs on this caliber in the future. Thank you so much for this opportunity. Dr. Williams, in this 2-minute period, would you like to just share with us briefly your original vision for ABC?
Say that again, please, Dr. Fletcher.
But in this next 2 minutes, if you'd like to briefly just kind of share the vision that you had 50 years ago for the formulation of ABC.
My goodness. Well, that really does take us back to the past. 50 years ago, we were back in the early 1970s, and the situation was very dire for African Americans or people of African descent in regards to our prospects, cardiovascular disease, and the situation that we faced with not receiving high standard care for our cardiovascular problems. And that incited me and others to think about the possibility that we needed to look intensively and particularly at our problems, that is, the problems of people of African descent, and try to do something to address them on our own. And that was really the attitude that I started with, and others joined me in initiating the effort that led to the development of the Association of Black Cardiologists in 1974. I could give a great more detail about that, but let me simply say that I am so encouraged, or was so encouraged at that time, that we got a great deal of cooperation from others who understood our purpose and our need to try to develop an organization that was particularly focused on heart disease, cardiovascular disease in Blacks. And that's how we got started. And that's the impetus that continues today.
Thank you, Dr. Williams. That's a great synopsis for a long storied history. Certainly, as closing, from my perspective, I want to take this opportunity to also thank Amogen for their support of this project and this program, and we certainly appreciate their involvement and their identification with the mission and the vision of ABC. I'll turn the program back to you, Paul.
Great, thank you. I believe our judges have finished, so if we can bring Dr. Haynes back on to announce our winners, that would be fantastic.
Yes, I am here. So thank you, Dr. Underwood, and Dr. Fletcher and team and Dr. Williams. So as we close today's program, I want to extend a heartfelt thank you to everyone who made this event a success. To our presenters, your work was truly outstanding. Each of you shared research that was very thoughtful, innovative, and deeply relevant to the future of cardiovascular care. We commend you for your dedication to excellence, and also would like to thank our judges. So thank you for your time and your expertise and thoughtful deliberation. Your role in helping identify and uplift emerging talent is incredibly valuable. A special thank you to our leadership and staff of the Association of Black Cardiologists. Thank you for your vision, your planning, the behind the scenes work to ensure that this program was possible and very impactful. We are also deeply grateful to our sponsor, Amgen, for their generous support. This competition and the opportunities it creates would not be possible without you. And now for the moment we have all been waiting for. We are thrilled to announce our 2 winners for this year's abstract competition. So our first winner is Dr. Pedro Pallangyo. So congratulations. We're giving you a virtual round of applause. And our second winner is Dr. Abubakar. So congratulations to our winners. Congratulations to both of you. Okay, good. So let's take a moment to congratulate our winners, but to all of our participants. Everybody is a winner. Everyone presented fantastic work, but congratulations to both of you. And as a reminder, your prize includes sponsorship to travel to the United States to present your research at the Association of Black Cardiologists meeting during the American Heart Association Scientific Sessions this November in New Orleans. So that's going to be a lot of fun. Looking forward to seeing you there. ABC staff will follow up with you directly to coordinate the details of your prize. So congratulations again to our winners, and thank you to all of today's finalists. Your contributions and your presentations made this an incredible program, our first international J. Brown competition program. So thank you again. Thank you to our judges, our sponsor, and everyone who has joined us today. So we look forward to seeing you at future ABC events and seeing our winners at AHA. So thank you, everyone, and have a wonderful day. That concludes our program.
Thank you.